You can share your slides.
Yeah. So I hope my slides are visible, right?
Yeah, visible, sir. Fine, sir.
Okay. So, so thank you again for inviting me. So what I'm going to try to do is, in the next 25 to 30 minutes, I'll be talking about a very important entity called post-COVID-19 or understanding. Sure. So what I'm trying to do is, I'll be talking about the basic tenets concerned with this particular topic. And so as far as management of COVID, post-COVID stuff is concerned, I'm going to invoke a lot of literature which is concerned with not directly with COVID-19, but it actually borrows from management of health from due to other conditions, post-viral or otherwise, and I'm going to talk about that. So briefly, we know all what tough is. I understand that this is an amalgamation of delegates who are present. So please pardon me, at times I end up seeing a lot of jargons which may not be really, which may not be clear to some of you. And at times it could appear that I'm presenting something which is too simple. But I'll just try to, present something which would be somewhere in between. Okay. So, you know what cough is? This is a rapid expansion of air from the lungs, which is a kind of a protective reflex. Now, what is important is, whenever we are talking about cough, whether we try to find out the cause, we try to diagnose the cause, or we try to manage it, we try to classify cough according to its duration. So, the most common classification is acute subacute chronic. So, anything less than 21 days is acute, subacute is typically less than 2 months. So 21 days to 2 months, the chronic is more than 8 weeks. So we have to keep that in mind because that is also again we are going to approach post-COVID cough. So cough again is one of the common symptoms in COVID-19. So we have already talked about that. The causes for the COVID-19 cough can be a number of reasons. So I will again come to that, but basically they are either pre-existing or they can be new also due to COVID-19. Now due to paucity of data, the natural history of this post-COVID-19 cough is still not clear. So the literature is still evolving. So we'll just see where we stand as far as literature is concerned and what more needs to be done in order to fully grasp the regular conclusion. Now, so this is, I just wanted to highlight how important this post-COVID-19 cough is. I just want to show you some data from US. People don't have the time of presentation, but also after 2 to 3 weeks after the onset of symptoms. So if you would just look to the right, the bar, so the light blue bar, they actually talk about the incidence of symptoms at the time of presentation, but the deep blue bar actually talks about the incidence of symptoms at 2 to 3 weeks post onset of symptoms. So if I can just zoom on to the cough thing. So what you'll see is that in COVID-19, cough is one of the commonest symptoms. So the acute condition can be present in more than 60% of patients, but even after 2 to 3 weeks, you can see that the cough is present close to 45% of patients. So the 3 weeks mark a significant proportion of patients are still having post-COVID-19 cough. See, as a part of post-COVID-19 syndrome, they might also be having other associated conditions with cough. So that is about the 2 to 3 weeks duration. And if we move ahead further ahead, so at the 60 days mark. So this is again from a US cohort, and it shows that at 60 days mark, around 18 to 20% of patients, around 18 to 20% of patients, they are still having cough. So if you see this post-COVID-19 follow-up, 60 days mark, we are seeing that close to 18% of patients they are having cough. Now, this is not only from the US cohort, you can also see from some European studies, which also talks about that at close to 80 days follow-up, we are getting close to 29% of patients who are still having cough. So what I wanted to emphasize was that cough is a common problem which is persistent in post COVID-19 sequel patients. Okay. So what would be the risk factors for developing post COVID-19 cough? Now again, the literature does not really offer a lot, but what is known is that this COVID-19 cough is there in patients who have sequelae. Now sequelae in the form of usually lung damage, either which is visible in the form of CT scan images or which will not be visible, and these sequelae they are known to occur in certain conditions. So which are, again, I think most of us know, extreme surgeries in old age, underlying malignancies, COPD, kidney disease, heart disease, obesity, and diabetic mellitus. Also, if the patient is having a pre-existing lung condition, then it might also increase the risk for poor COVID-19 outcomes, lung damage, and other conditions. And this might also give which might lead to increased chances of having post-COVID-19 cough. So briefly, I won't go into detail. If you talk about cough reflex, this is something which we are all probably studied in our physiology classes and our medicine classes. So cough reflex, it occurs due to the mediation of the active pathway, which is the receptors. Now, what is important to remember about the receptors is this receptor is present not only in the larynx, the respiratory tract, trachea, bronchi, but it is also present in the pleura, pericardium, diaphragm, esophagus. So this will be important when we look at the causes of post-COVID-19 cough. So these are the receptors. It is signals to the center, it is being modulated, and there are signals sent by the receptor, and there is violent contraction of the expiratory muscles, diaphragm, and there is expansion of air leading to cough. So this is what the cough reflex. Now I would like you to just remember these for a certain point because these will be helpful later on. Now, whenever we approach cough, I told you we approach it in the form of whether it is acute, whether it is subacute, or chronic cough. Now, whenever we talk about acute cough, say in any condition, what are the common causes that come to our mind? So the common causes are mainly respiratory tract infection, be it upper respiratory tract infection, lower respiratory tract infection, pneumonia, heart failure, or some other conditions like asthma or COPD. And normally what we do is we take a good history, we run some tests, we do an X-ray, and then we reach the particular diagnosis and we institute treatment. For subacute cough, so for cough between 3 weeks to 8 weeks, again the most common causes are something called the USCS or upper airway cough syndrome, or it may be an exacerbation of pre-existing condition like asthma, COPD, so acute exacerbation of asthma or COPD, or an exacerbation of bronchiectasis. It might also be due to a condition called GERD or gastroesophageal reflux disease. Now, normally, how do we approach a patient of subacute cough? We do it in the proper manner. Again, history is important. Then we usually go for an X-ray chest. We run some lung function test if the patient is bringing out sputum, an induced sputum test, and then we reach a particular diagnosis. In some of the cases, the diagnosis they are not reached. Then normally we institute treatment covering these common conditions like GERD, like upper airway cough syndrome, or asthma. And most of the times, the patients they end up their cough becomes better, and they get symptomatic relief. So this is about the subacute cough. And regarding chronic cough, again, apart from the other conditions which are there in the subacute cough, that is USCS, upper airway cough syndrome, exacerbation of the pre-existing conditions, and GERD, they might be due to other conditions like, say, pneumonia, again, pleural effusion. And normally in these patients, what we again do is we take a good history, we look for red flag signs. I'm going to talk about them. And normally what we do is then we try to address these conditions, USCS, asthma, or GERD, in the form of diagnostic like sinus imaging, or we go for asthma for a spirometry, or for GERD we normally go for we go for a 24-hour pH monitoring if it is available, and then we start appropriate treatment. So chronic cough again, so these are the common conditions, the 4 conditions: upper airway cough syndrome, asthma, GERD, and in some cases non-asthmatic, usually bronchitis. Right. So what is in cough is something which I've highlighted. So this is something which I've highlighted. So the causes which we talked about the causes, we talked about the, so we saw that the acute remission, they were most common in patients having respiratory tract infection, asthma COPD exacerbations, disturbative cough, they are most common in post-infectious cause, asthma COPD exacerbation and the chronic cough, they mainly occur in USCS, asthma, GERD, and sometimes non-asthmatic, eosinophilic bronchitis. Now once we know, we have thought about the cause, next what is important is before diagnosis, we usually look at the severity. Now this is something which is commonly not done, but this is very important that we do it, because by gauging the severity, we can fully appreciate how the therapy would be helping the patient. So we can gauge the measure of therapeutic benefit with the help of certain scales. So these scales are commonly used. So these are called the Kuhnau ladders. So normally we tell the patient to mark their cough severity, and they can easily mark it. So for people who cannot even read, these findings of the pictorial diagram, they can also help in gauging the severity of cough. So after you have gauged the severity, normally a diagnosis is done, which usually involves a physical examination and PFT and chest imaging. Now this is common in most of the conditions across the spectrum of acute, subacute, or chronic cough. And the treatment of the particular cause is instituted, and that's how we generally approach cough. So, what is different in COVID-19? What is different in post-COVID-19? Well, the difference is, as I tried to highlight, is the evolving literature of the causes of cough in post-COVID-19 syndrome. Now, some of the causes, like say post-viral cough or cough hypersensitivity, or say lung fibrosis. Now, these are some of the causes which we can conjecture based on our experience with previous viruses. These are some of the causes which sometimes we can see on an X-ray. So, on an X-ray, we see that the patient is having fibrosis, the patient is having cough. We might surmise that the patient is having the same due to the lung fibrosis, but still, the exact burden of conditions like USCS or cough hypersensitivity in COVID-19 is not known, and the literature is still evolving. The common diagnostic test, one of the common diagnostic which we commonly use, that is a PFT, again, maybe very challenging in family situation because of the risk of transmission of infection by aerosolization. So we are going to talk about that subsequently. And finally, the treatment, if you talk about the treatment, again, the literature is evolving. We end up using the treatment which we give for other conditions, but we do not exactly know which treatment has got the best efficacy and if any modification of the treatment is warranted. So some studies are going on, and probably some definite information may be available after these studies are complete. So as far as COVID-19 cough is concerned, so if you look at the causes, so these are the common causes that we can think of, or some of them have been reported in literature. So these are post-viral cough, upper airway cough syndrome. This may be due to an exacerbation of asthma or COPD. This may be very well due to the fact of the virus replicating and respiratory tract infection, either due to COVID-19 itself or due to superadded bacterial infection. It may be due to the damage of the COVID-19 virus, leading to bronchial dilatation or bronchiectasis, or it may be due to lung fibrosis. It might go directly not related to COVID-19. It might be related to some underlying conditions like lung cancer, or it may be due to aspiration pneumonitis. The patient is aspirating, and that is leading to lung inflammation, causing aspiration pneumonitis. It might be also due to something called pleural inflammation or pleural effusion, or it may be due to cough hypersensitivity syndrome. So some of these post-viral cough, USCS, cough hypersensitivity, and other conditions I'm going to talk about. So these are the respiratory causes of post-COVID-19 cough, or it may be due to non-respiratory causes like GERD. We know that in patients who are critically ill, the incidence of GERD may increase. It may be due to some drugs which have been started during the stay in the COVID-19 ward or ICU. It may be due to exacerbation of heart failure. It may be due to post-infectious vagal syndrome, or it may also be due to the pericardial inflammation, because we saw that the afferent receptors for cough, they reside not only in the respiratory tract but also in the pericardium. So that might also give rise to inflammation and COVID-19 cough. So talking about briefly about the different conditions which we should be acquainted with if we are trying to understand how these conditions lead to COVID-19, post-COVID-19 cough. So first is the USCS, or the upper airway cough syndrome. So this is related to the post-nasal drip or the nasal catarrh. Typically what happens is the patient complains of something dripping at the back of his throat, and these secretions again they lead to excitation of the receptors and coughing. And the patient, apart from the drip, they also complain of frequent nasal discharge, frequent throat clearing, but sometimes no such history may be forthcoming and the patient may not complain of anything. So the clues on physical examination. So when we are doing a physical examination, say in a COVID-19 survivor, so the thing which we would be able to see is the conventional appearance to the nasopharyngeal mucosa. We can also be able to see some mucus or in some cases a mucopolluted secretions in the nasopharynx. So something like this, a conventional appearance, a red angry looking thing might give us an idea that there is some inflammation or there is post-nasal drip going on, and we should be suspecting USCS. So previously the USCS entity was thought to be seen as post-nasal drip, but nowadays it is realized that it may be due to a number of conditions of rhinitis, allergic, non-allergic, bacterial, fungal, or it may also be due to post-infectious rhinitis, and so it can also be seen in patients surviving COVID-19. Right. Okay. So regarding the next entity for the post-viral cough, so this is a lingering cough that follows a viral respiratory tract infection. Again, such as common cold or flu has been commonly reported, and it's thought that in patients with post-COVID-19 cough, they might also be having this. So several possible interrelated mechanisms are thought to be responsible. Apart from the post-nasal drip, this might also be due to enhanced sensitivity of the airway nerves, probably as a result of the virus-induced damage. It might also be due to airway inflammation following acute viral respiratory infections. So post-viral cough may also be due to these seen in post-COVID-19 patients. And usually they last up to 8 weeks. They are typically one of the common causes of subacute cough. The diagnosis is usually clinical, and since the national course is self-limited, there is no role of antibiotics, usually antitussives or inhaled ipratropium or other symptomatic treatment. They are instituted. Next is another condition called hypersensitivity, cough hypersensitivity syndrome, where there is the nerve endings and the afferent neural pathways are hypersensitive and they lead to chronic refractory cough. So they can be considered similar to a chronic neuropathic pain, that is, there is nerve damage due to the virus or due to the associated inflammation. And typically there is dry cough, sensitivity in throat, and they usually become worse when talking, laughing, or exertion. Now this is something again which some of us have encountered after a viral infection. We see that whenever we talk or we laugh, this condition is exacerbated. So that is typically what is seen in cough hypersensitivity syndrome. And this again is a common cause of both subacute and chronic cough. So this might actually for years at times. Usually no diagnostic tests are available. So this is a diagnostic exclusion. Treatment again is mostly symptomatic in the form of antitussive, antihistaminics, and sometimes steam. Now, somewhat related condition is post-viral vagal neuropathy. So this is a clinical entity characterized by a complex of laryngeal symptoms that usually begin after URI, so it might also be seen in patients having COVID-19, where cough is a predominant symptom, apart from throat clearing, dysphonia, and vocal fatigue. Usually occurs in middle-aged to elderly people, and here the laryngoscopic findings, they are usually typical. It shows some vocal cord reduced movement, and there might be some evidence of reflux. The treatment in this case is usually due to voice therapy, anti-reflux therapy, and in some cases surgical maneuvers like vocal cord revitalization. Now, GERD is a common entity, gastroesophageal reflux, So what happens is, due to the reflux, there's stimulation of receptors in the upper respiratory tract. There's also, there will be aspiration of gastric contents, leading to stimulation of receptors in the lower respiratory tract as well. And an esophageal trachea bronchial cough reflex induced by reflux of acid usually occurs, and even trans aspiration pneumonia may occur due to gastroesophageal reflux. So this is associated with esophageal dysmotility, and the patient sometimes in 60 to 70% of the times might complain of heartburn. And the reflux or the cough usually increases when the patient assumes a supine position and also sometimes in upright position. It can also be seen not only as a primary disease but also as a sequelae to infection. So COVID-19 patients, their body, they are going through stress. So there is hypersecretion of acidity, there is more chance of sympathetic stimulation and lower esophageal sphincter relaxation, and that can give rise to more incidence of gastroesophageal reflux and more chance of patient having cough. Now, somewhat associated condition is the LPR or the laryngopharyngeal reflux. So here the gastric contents, they are moving into the laryngopharynx. So usually it's an upper esophageal sphincter problem that mainly occurs in the upright position during periods of physical exertion. And direct laryngoscopy evaluation can assist in the diagnosis of cough, where there is some of the inflammation seen in the laryngeal area, and usually the treatment is in the form of acid suppressive therapy. Now this is again something which is usually associated with GERD, and this, like GERD, might also occur in post-COVID-19 patients. So the treatment for GERD and LPR, again, what is intuitive is the pharmacological therapy, but this is not the only therapy which is available. Non-pharmacological measures like reducing body weight, stopping food, beverages that increase symptoms, not filling one's stomach to the full, avoiding recumbency immediately post-meal, and lifestyle modification in the form of stopping smoking and alcohol. These are important aspects for the treatment of GERD. Now, moving next on to the parenteral cause. Now, structural lung damage is again a common cause of post-COVID-19 cough. Now, so this is a picture from a patient in Austria. So, if you would see that, so this red lung actually indicates that the inflammation, acute inflammation in a patient having acute COVID. As time goes on, 3 weeks, you can see some of the healing, green past the healed areas, and as time goes on, say months, what we see that the red areas, they have not fully disappeared, indicating that some amount of structural damage is seen. So, so this is again something which we all we are actually keeping COVID-19 patients. We have seen that the lung damage in the X-ray, lung damage in the CT, they are persisting even after the patient is being discharged. So, so this is about that. So this lung damage may be in the form of bronchial damage, bronchial thickening and bronchiectasis. It may also be in the form of diffuse alveolar damage, which is an aftermath of the ARDS. It might be due to lung fibrosis, and it might be due to again pleural reaction, effusion, and thickening. So if these conditions persist, now these conditions, they can also give rise to damage of the, damage and excitation of the afferent receptors of cough, leading to post-COVID-19 cough. So lung fibrosis, I understand that Dr. Ved will be talking about lung fibrosis. So this is a condition where the COVID-19 virus, by using some of the ACP receptors, they enter the patient's lung, leading to fibroblast proliferation, other epithelial damage, and the end result being excessive deposition of collagen and pulmonary fibrosis. Now, when this pulmonary fibrosis occurs, there is a stimulation of the afferent receptors, and these afferent receptors lead to ultimately cough. So these patients, they typically present with cough and other features like fatigue, and in some cases, if the damage is significant, they also present with shortness of breath. Now the treatment, I would not go into the details. So there is a lot of literature, evolving literature regarding this. So the role of the different antifibrotic agents, steroids, I'm sure Dr. Ved will be talking about it. One such entity which has been highlighted during COVID-19, that is pulmonary embolism, that is also important and is an important, not an important, but thought to be one of the putative cause of cough in COVID-19 patients. So pulmonary embolism, it is thought that COVID-19, these patients have got higher incidence of pulmonary thromboembolism, and these patients of pulmonary thromboembolism, they might die, or um, they might survive without any sequelae, or in some cases what might happen is that these patients might end up with something called a CTEP, or chronic thromboembolic pulmonary hypertension, where there is persistent thrombus and fibrosis in the pulmonary vasculature leading to increase of the pulmonary circulation pressure. And this pressure, and due to other causes, there might be post-COVID-19 cause. So some cases of COVID-19, you might end up with CTEP, and this CTEP patients might have cough, which are having other features like dyspnea, and some cases hemoptysis. Now, after COVID-19, if the patient is admitted in the ICU more so, or even after the patient has been discharged, due to the damage to the lung, these patients, they end up being vulnerable to further infection. Further infection, it might be in the form of a bacterial UTI, second pneumonia, some cases it might be fungal infection, or it might be due to the decreased immune status, it might be due to the unmasking of the latent tuberculosis, or in some cases due to. So these infections, if they are occurring in COVID-19 patients, then they also can give rise to cough. So it's very important that in cases where infection, they are suspected infection, we do appropriate tests in the form of X-rays, the examination, and we institute appropriate treatment in the form of antibiotics, antifungals, and other therapies. One entity where none of the anatomical or none of the pathological factors they are thought to give rise to post-COVID-19 cough, it is hypogenic cough. They usually occur after URPI, they also occur after COVID-19 infection. So here the cough actually persists for a long time. Typically the patient may present with chronic cough. Typically the cough may be of a harsh barking characteristic. And what is characteristic is that these patients, they report no problem in sleeping, or when the patient is distracted, the cough disappears. This might be seen in young age, but in other patients as well, might be associated with mental, some psychiatric illness, including depression. So the treatment is usually in the form of psychosocial intervention. Now, this is one cause where there is a diagnosis exclusion. Once you have ruled out all the causes, and you cannot put the finger on what the real cause is, you can pick to what possible. So what is important is that whenever we are approaching a patient with cough, we have to look for the red flag signs. So what are these red flag signs? Means if these signs are present, then you won't take this cough to be an innocuous entity. You won't take this cough to be due to just some post-COVID-19 lung damage. Rather, you would up the ante. You would try to institute. You would try to run some tests as required, and these and exclude all the possible causes before you label them as to be innocent cause. So what are the red flag signs? These are important to know the patient is having hemoptysis, and the patient has been a smoker and is more than 45 years of age. Patient is having some complaints like hoarseness, systemic symptoms like fever, peripheral edema, vomiting, veterinary pneumonia. A patient has an abnormal respiratory examination or an abnormal rest radiograph where which is not seeming to be due to post-COVID-19, or where the patient is elderly, more than 55 years, and has got again a significant smoking history, or where the patient has prominent dyspnea, especially at rest, or complain of orthopnea, or they have some other symptoms due to medicinal pathology like dysphagia and others. So these are the red flag signs, and these are the cases where you would like to investigate more in order to reach a particular diagnosis. Now, in all these patients, whenever a patient is post-COVID-19 cough, whenever he presents, when you are ordering the test, normally what happens is a PFT is one of the tests which has been commonly ordered, but now due to COVID-19 pandemic, a lot of places they have still not started their pulmonary function lab services. So what is regarding that? So whenever any case where a patient is pulmonary function lab is running, it is very important that we lay emphasis on the cleaning and the infection control as well as the protection of the healthcare workers, and we have to also ensure social distancing and the patients properly ventilated. So it is not that these COVID-19 patients, they are such pose problem to the healthcare workers or the other person in the lab, because after 10 days, usually the patients, they are rendered non-infectious. But what is important is that as such, since due to this COVID-19, uh, we are exercising more cautiousness, more caution. So it is important that we follow these protocols whenever we are running a pulmonary function test lab. So normally what happens is that whenever we get we do a spirometry in these patients, the most common abnormality which comes up is the diffusion of lung abnormality or the restriction of lungs. So this is some data from Wuhan, from where it all started. And you can see that they had actually evaluated more than 140 patients, and they had shown that the diffusion, the decrease in the diffusion capacity was one of the common problems, followed by the restriction of the lungs. So this was a common problem, and the obstructive problems, they were very less, and they were also not significantly distributed among the mild, moderate, or the severe pneumonia. Regarding chest imaging follow-up, so if you are doing, if you are following up the patients with chest imaging, what is important is that we have to remember that most of the chest radiograph findings which are present, so be it GGOs, be it fibrous stripe, be it some bronchoscopy bundle distortion, or the thickening of the pleura, or diffusion, they usually with time they tend to get attenuated and they tend to disappear. So this was again a study from Wuhan. It followed up patients every month, and it was seen that all the conditions, GGS, fibrous stripe, vascular bundle distortion, and the thickening of the pleura, etc., they gradually decreased with passing time. So the CT scan pictures, they also talk about this. So these are fibrous stripes, they are gradually getting lighter. Also the GGOs, they are present, we are also seeing that they are gradually getting better. So even if you are following patients up, normally what is expected is that these patients, they will be showing improvement in the radiograph condition or the CT conditions. So whenever we see a patient of COVID-19 who is presenting with significant cough, so this is how I think I would like to approach this patient. So I would talk to him and I'll ask him the history about any pre-existing condition. I will know about his present condition and how it started, what is the nature of cough, what are the associated symptoms. History will be important, followed by a physical examination starting from the upper respiratory tract to look for features of USCS. I might also take a ENT evaluation if the patient, especially if the patient is not responding, and we can look for some vocal cord abnormalities, some features of LPR, laryngeal flux. And then I would order an imaging in the form of X-ray followed by a CT scan. A lung function test would be indicated, and so again, what we normally would expect would be some changes, be it restrictive or decreasing diffusion. And depending on the findings from all these, I might end up on other tests like echocardiography, bronchoscopy, field monitoring, and so on. So most of the time, what is seen is that these patients, they do not have, apart from some amount of lung damage, they do not have much other findings from all these history, physical examination, radiograph, and cardiography. So normally we end up giving these patients a cocktail of therapy in the form of antipersive, some inhaled medications, be it propion, sometimes even steroids, and some non-pharmacological measures like cough control. So mainly for patients who have subacute chronic cough, So non-specific treatment or antitussives we are talking about. So normally two types of antitussives are used: dextromethorphan, codeine morphine, and peripheral like levofloxacin, levofloxacin. These are commonly being used. So inhaled agents, the common in the form of, as I said, ipratropium inhaled steroids, and non-pharmacological measures like breathing exercises or cough suppression techniques can also be used. So this is more or less what I wanted to say. I would like to just summarize it briefly. This is I think my last slide. So post recovery from COVID-19, cough may be one of the most common symptoms. And if you are approaching cough, then we should be approaching it as we approach cough normally. That we should try to think whether it is where the patient is post COVID-19 recovery, whether he is having acute, whether he is having subacute, or whether he is having chronic cough. We should always inquire about red flag signs. So in these patients, as I said previously, that we should not be taking it lightly, and we should not think that this will just go away with time. Rather, we should be more aggressive diagnostically and therapeutically. And pre-existing conditions. So whether the patient had a pre-existing asthma, COPD, which might simply play up during the COVID-19 infection, they should also be kept in mind. The exact outcome of COVID-19 disease, obviously it is sequelae is still not known, so it is very important that we follow these patients up and we learn as we follow these patients up and follow a number of patients over a long period of time. And proper history, relevant investigations and reference required will help us understand and keep better. So that is all I wanted to say. I'd like to end with that. Thank you.
Yeah, thank you very much, Dr. Animesh. So, I'm audible? Yeah, excellent presentation. So, we'll go for the question and answer session next. I think another 3 speakers are there, so I request them to please constrain the time for the 20 minutes. So, now I invite Dr. Ved Prakash Meena from All India Institute of Medical Sciences, New Delhi, for his talk on post-COVID pulmonary fibrosis.
Thank you, sir.
Yeah. Dr. Animesh, can you exit your slide?
Yeah, sure.
Yeah.
Stop sharing.
Yeah. Wait, you can share now.
Is it visible, sir?
Yes. Full screen. You can go for the full screen. No? Yeah, now we can. 20 minutes, well? Thank you.
Thank you, sir. So I would like to talk about post-COVID pulmonary fibrosis. I talk about pathogenesis of post-COVID pulmonary fibrosis, followed by lessons from what we have learned from previous coronaviruses like SARS and MERS, and then potential therapeutics for this fibrosis. And in the last, I'll talk about respiratory follow-up COVID-19 patient. What is the proposed model? So as everybody knows, COVID-19 disease is caused by SARS-CoV-2 virus, which can cause variable symptoms ranging from mild upper respiratory tract infection symptoms to severe acute respiratory distress syndrome. I will not go into much depth about this. I will directly go to what our study has said for COVID-19 pulmonary fibrosis. In this study, there was followed by CT scan and physiological abnormalities. Pulmonary function tests were done at the 3 months after discharge, after recovering from COVID-19 infection. Found that there is higher level of D-dimer on admission was a predictor of better DLCO after 3 months. So it is necessary to follow up the COVID-19 patients to appropriately manage any persistent or emerging long-term sequelae. The other study, the retrospective review was done with CT scan, where they found that multiple GGOs decreased from 80% to 23% after 4 weeks of discharge. Similarly, there is decrease in the interlocular septal thickening from 80% to 35%, and subpleural lines reduced from 39 to 7%. So lung fibrosis after coronavirus infection is not permanent, neither irreversible. Abnormality in chest imaging decreases gradually after 2 months after follow, after recovering from COVID-19. Similarly, lung lesions of 25% were fully resolved in the first CT scan after discharge, and rate of lung recovery increased to 64% after the second follow-up after 1 month. Now coming to pathogenesis of pulmonary fibrosis, as in every diseases, pulmonary fibrosis is the consequence of inflammation, which is characterized by persistence of fibroblasts and excessive deposition of collagen and extracellular matrix, which leads to the destruction of normal architecture. Then there are many cytokines involved in the pathogenesis of fibrosis, like TGF beta, FGF, PDGF, and other cytokines also, which causes cytokine storm. So, this progression of pulmonary fibrosis leads to uh, impairment in gas suction capacity of lung. So, what we have seen that cytokines overexpression in fibrosis is interleukin 1, interleukin 6, NF alpha, and GF beta. All these are increased in fibrosis. Similar cytokine levels are elevated in previous coronaviruses like SARS and MERS, and again now in COVID-19. Apart from other interleukins like interleukin 12 and GCSF. So, similar pathophysiology of cytokine overexpression is seen in SARS, MERS, and COVID-19 also. Now coming to molecular mechanism of pathogenesis of pulmonary fibrosis and SARS-CoV-2 infection. There is upregulation of TGF beta level caused by SARS-CoV virus and downregulation of H2 levels, which increases angiotensin 2 level, which again increases TGF beta 2 level. TGF beta level increases SMAD protein activity, and along with these TGF beta and SMAD pathway and other H2 angiotensin 2 and CTGA pathway, both leads to the accumulation of ECM and fibroblast activation, which leads to the lung fibrosis. There are 3 phases of pulmonary fibrosis. The first is there is acute exudative inflammation in the first week, which is caused by initial viral damage. Further, in the second week, there is fibrous proliferation, similar to what we have seen in proliferative interstitial pneumonia, where mesenchymal cells differentiate into fibroblasts and myofibroblasts. Then, after 2-3 weeks of COVID-19 disease, there is fibrotic stage, where there is numerous type 1 and type 4 collagen fibers are there. So, as Dr. Anvesh has already said, this pulmonary fibrosis presents with the diet fatigue, weight loss, and dyspnea. Now here also you can see there is alveolar epithelium damage caused by SARS-CoV-2 infection, which leads to the overexpression of pro-inflammatory cytokines like TGF, beta, TNF, and interleukin 6, which causes increase in ECM accumulation and fibroblast. And there is excessive deposition of collagen in extracellular matrix. SARS-CoV-2 infection is coronavirus. Previously, we have seen diseases from other coronaviruses like SARS and MERS. Because we are still not much is known about the long-term outcome of COVID-19. What we have known is from previous diseases caused by other coronaviruses. The SARS and MERS also survivors of SARS and MERS also describe long-term damage and pulmonary fibrosis, which results in reduced quality of life and there is significant disability. What we have seen previously with severe acute respiratory syndrome is after 1 year follow-up in this study, there is significant impairment of diffusion capacity of lung for carbon monoxide, uh, which was noted in around 24% of survivors 1 year after illness. And their exercise capacity and health status of survivors were also lower than those of normal population at that time. Not everyone develops pulmonary fibrosis in COVID-19. After COVID-19, there are few risk factors like advances. Then, as we can understand, severe illness, which leads to increased length of ICU stay and mechanical ventilation. All these causes increase in, all these are associated with increased inflammation and lung damage. Uh, Other factors are smoking and chronic alcoholism. What is the difference between other interstitial lung diseases like IPF and lung fibrosis, which develops after ARDS, and how does it differ from ILD? What we have seen in another study also during follow-up imaging finding, and that it is non-progressive, unlike other ILDs, where IPF is chronic progressive fibrosing disease. Uh, in lung fibrosis, which develops after ARDS, secondary to SARS-CoV-2 infection or other coronaviruses, MERS and SARS, it is non-progressive, and most of the damage occurs early in the course of the disease initially, and it may partially improve during early follow-up also. Uh, in, in previous studies, survivors of H1N1 ARDS are improved at 3 months after hospital discharge, but there was no improvement after 3 to 6 months, and quality of life continues to improve till 6 months after discharge. Uh, Other coronavirus disease, SARS patient, uh, surviving SARS patient was seen at least twice within 3 months after discharge. In that study, diffusion capacity improved in around 80% of patients, where 51 patients were observed. And out of 51, 20 patients showed improvement in lung fibrotic changes 1 month after disease. So it is a non-progressive fibrosis which will improve partially on early follow-up. After knowing the pathogenesis and mechanism behind the fibrosis after coronavirus infection, so what can be the potential therapeutic measures to prevent or to treat the fibrosis? Uh, because even patients who have viral infection have fibrotic tissue disease in them, respiratory dysfunction even after healing. There is role of antifibrotic drug therapy in patients with ongoing infection or in patients who have the disease, but it has to be still be defined. Potential therapies. There are some similarities between IPF and COVID-19 in pathophysiology, like cytokines involved are around same. So drug useful for the treatment of IPF are hypothesized to be useful for patients with COVID-19 also. But important factor is timing of the onset of antifibrotic action. As we have seen that in the SARS-CoV-2 infection or other viruses, uh, fibrosis develops early and it is severe at the starting only. So timing of the onset of antifibrotic action is important, and then so it can be ineffective also. Further studies are needed for that. So these are the measures that can be useful. Um, as we have talked about drugs for IPF, which can be used antifibrotic drugs. Two antifibrotic drugs are currently in use for IPF, which are pirfenidone and nintedanib. So they can be useful also in pulmonary fibrosis, uh, which is caused after ARDS, secondary to SARS-CoV-2 infection. The measures are not actually therapeutic. They are helpful in they are helpful in preventing fibrosis, like antiviral drugs. Antiviral drugs, if we use early in the infection, they can lead to the decrease in alveolar damage and subsequent inflammation, uh, leading to less fibrosis. Another factor is like Another factor is one pathogenesis in the ventilator perfusion mismatches. There can be microthrombi in the endothelium in the capillaries. So it can cause alveolar damage. So one proposed hypothesis is that fibrinolysis can be used to prevent fibrosis, like streptokinase and tissue plasminogen inhibitor. Another factor important is aldosterone. Apart from causing hypertension, it is also important in causing fibrosis and inflammation. So aldosterone antagonist spironolactone might be useful. Another is hyperbaric oxygen and mesenchymal cell transplants. We'll see. What can be the best regimen for that, for preventing or treating fibrosis? Like with using antifibrotic, we can use immunomodulants. In the initial stage for decreasing inflammation, we can use IL-6 inhibitors like tocilizumab or steroids, which can decrease inflammation and prevent severe fibrosis. With the use of antifibrotic agents like pirfenidone and nimdatinib, which can be effective pharmacological synergies. Then other drugs unique to the COVID like anticoagulants, fibrinolytics, antivirals, steroids, apart from spironolactone. So what can be the role of antifibrotic therapies in COVID-19? It should have rapid onset of action, which we don't know yet. It should be instituted early before mechanical ventilation, because most of the damage and fibrosis occurs that time only. It should be of non-oral group for critical ill patient. Now nebulized pirfenidone is also in trials. Then it need to be combined with other anti-inflammatory drugs. So we can't say that single antifibrotic drug will be more useful. We should combine it with other anti-inflammatory drugs. But currently there is no basis for ethical or licensed treatment. Further study and research is required to be done, which can be evaluated in these conditions. Like if they can prevent severe COVID acute existing in pre-existing ILD patients, or can they be effective in preventing fibrosis in COVID-19 patients without pre-existing ILD, or can they treat fibrosis in COVID-19 patients without pre-existing ILD? So these things to be keep in mind while doing further research and study. Now coming to this antifibrotic agent which is used frequently in IPF, pirfenidone. It could inhibit apoptosis. It also downregulates S receptor expression and decrease inflammation by several mechanisms and ameliorate oxidative stress, and by these mechanisms it protects monocytes and other cells from COVID-19 invasion and cytokine storm simultaneously. Phase 2 and phase 3 trials are underway for nintedanib, pirfenidone, and other drug is tetramethaine, and then mesenchymal stem cells and hyperbaric oxygen. Our result is awaited for these studies. Dosing which we use for pirfenidone is IPF is 267 mg 3 times daily for first week, followed by 534 mg 3 times daily in the second week, and then subsequently 800 mg 3 times daily. There are minor adverse effects like GI side effects, rashes, transaminitis, and dizziness. Other antifibrotic agent we have talked is nintedanib. It is a tyrosine kinase inhibitor which inhibits various growth factors like FGF, PDGF. It also has similar side effects, gastrointestinal, rashes, and transaminitis. But it is a costly treatment. 1 month treatment costs around 85,000 rupees. The Another therapy which can be useful is mesenchymal stem cell therapy. So, in this, after the intravenous transplantation of mesenchymal stem cells, there is a significant population of cells which accumulates in the lung, which causes which have immunomodulatory effect and can protect alveolar epithelial cells, and further preventing pulmonary fibrosis and reducing lung dysfunction. So, this was the first case of COVID-19 patient, which was infused with human embryonic stem cells in the China. Here we can see that first imaging is 6 days before human embryonic cells transfusion. After that, there is recovery till day 33. At day 33, we can see significant improvement in lung findings. So, if nothing works, then there is lung transplant. If there is severe fibrosis, patient is not maintaining saturation even on oxygen, then there is option of lung transplant. So, how should we follow up the COVID-19 patient after discharge? It is important to identify patients who are at risk for post-COVID sequelae, like elderly patients with severe disease, who are smokers. Um, Proposed model is that they can visit after 1 month and then 3 months. Investigation, chest X-ray, EFT, CT scan, and echo should be done at that time during follow-up. So this is the timeline. After 1 month of discharge, we will assess patient for post-COVID-19 holistic assessment. Then after at the second visit, after 3 months, chest X-ray should be done. There should be complete clinical examination. Consider 6-minute walking test and complete post-COVID-19 holistic assessment. If there is some abnormal chest X-ray or physical impairment or any evidence of pulmonary vascular disease, then HRCT scan is required. If there is evidence of interstitial lung disease or pulmonary vascular disease in CT scan, then it is treated accordingly. So we have talked almost everything about fibrosis. So in the last, it is important to have high index of suspicion and to follow up every patient of COVID-19 to detect post COVID-19 sequelae. Immunocompromised patients are at high risk of this complication, and fibrosis after ARDS and SARS-CoV-2 progresses rapidly. Still, there is no recommended drugs. What we are extrapolating is from previous studies and potential role of antifibrotic agents, pirfenidone and nintedanib. So, at the last, a comprehensive follow-up of all COVID patients is necessary, since there is possibility of a large number of such patients in the coming future.
Thank you, Dr. Ved Prakash Meena from AIMS New Delhi. So, excellent presentation over the pulmonary fibrosis, as there is inflammatory response and increased sensitivity and probability of the long COVID clinic and the respiratory clinics are needed to treat this pulmonary fibrosis. Still, the two drugs are going on, so but the nintedanib is little bit costly compared to the pirfenidone. So wherever the indication is there, so I request all the clinicians to use this little bit early. Please prefer the pulmonary function test is very, very important. We will discuss later in the question and answer session. I think there is some problem in the net with Dr. Sandeep. So I request that Dr. Shiva R.K. Vikmala is from UK, consultant respiratory physician. Would you please go to your talk, Dr. Shiva?
Hi, Dr.
Are you online?
Can you hear me? Can you hear me? Okay.
Yeah, please.
I'll start with sharing my screen. There's a technical issue, just a second. Are you able to see my screen, Dr. Rambabu?
Not yet, sir.
Okay.
Oh, sir,
I just need to.
Can you share the slides to me?
or sir, please take the slides, or we can share it on screen if nothing works out.
కాదురమ్మా. రాజు
Hello, everyone. Dr. Rambabu,
Yes, you're audible.
I am audible. Can you see my slides?
Yes, the screens are visible. Please, keep it on full screen.
Okay. Thank you.
Yeah.
Thank you very much for the invite regarding the pulmonary rehabilitation post COVID-19. I am Dr. Shiva Ramakrishna Pitmala. I'm a consultant respiratory physician at University Hospital North Midlands, UK. I think we just need to, it's important that we need to understand that as a doctors, we need to prevent the diseases, treat appropriately the conditions we can treat, and most important thing is rehabilitation. So I think my previous speakers has alluded nicely to what the COVID-19 has done to the patients, what are the sequelae of COVID-19 is, and how we treat these conditions. So I am very simply, my task is to concentrate on rehabilitation. So my agenda of this talk would be a little bit of background of what the pulmonary rehabilitation is, what has been done so far with other chronic respiratory conditions, what we know about the coronavirus infections in the past and current COVID, and we talk about organization and planning of pulmonary rehabilitation, its delivery, and what we're looking at, what are we aiming to achieve the outcomes. So going further, we know that any patient who has a COPD, for example, with each and every exacerbation, there is an increased risk of myocardial infarction and stroke. All cause and any cardiovascular comorbidity increases post-pneumonic exacerbations. So COVID-19 pneumonia is essentially an exacerbation leading to hospitalization for COVID COPD patients or non-respiratory patients who are well in themselves. And when these exacerbations do happen, what we notice is that cardiovascular events happen, and there is an increased risk of mortality. And each hospitalization leads to further hospitalization. So it is essential that we need to break this chain of exacerbations.
So what we know from other chronic respiratory conditions where we use the pulmonary rehabilitation. So for example, if you look at COPD, there was a large cohort of data, there is a Cochrane reviews, and what we know is at 1 year, when we put the patients with COPD, there are stable COPD patients or patients who present with exacerbation, there is definitely reduction, almost 7% reduction in hospital admission with each session. So cumulatively, it increases the patient to be staying safe at home, having a good quality of life. When we also looked at a follow-up of patients when they had pulmonary rehabilitation, there is an increment when we do physiological analysis on patient's shuttle walk test improves, endurance test increased by 44 seconds, and so forth. Similarly, when we look at the cohort of patients with ILD, there is an improved 6-minute walk distance by 44.34 meters, increased peak oxygen uptake, and reduced dyspnea. So these are the essential parts of the pulmonary rehabilitations, and we've been using it for a multiple number of years, and it is the essential part of the treatment strategy for any patient with a chronic respiratory illness. When we look at the evidence behind the pulmonary rehabilitations, when you have patients with a COPD, either it's stable or post-acute, there is an improvement in exercise tolerance, quality of life, decrease the exacerbation of hospitalizations, their symptoms get better. The physical activity levels, although there hasn't been any significant improvement, patients' anxiety and depression levels also shown to be improved. And this is a nice pyramid when we look into the management of COPD patients or any chronic respiratory patients. If you give the patients a flu vaccination, which is, in UK we use a quality of life assessment, which is called a cost per quality. If you give flu vaccination, it only costs about £1,000. If you give a stop smoking assessment, which is an essential part of treatment of COPD patients, it's only a little, costs more than £2,000 for quality. And pulmonary rehabilitations, although it's slightly more than smoking cessation and flu vaccination, it has a marginal, significant benefit, and the cost keeps on growing. I think we give a lot of treatment. I think when we go back, we just need to step down and see what the importance of pulmonary rehabilitation is, what is the importance of smoking cessation. This is a bit of background behind the pulmonary rehabilitation and how essential and important aspect in management of chronic respiratory illnesses. I think this slide has been recently talked about by Dr. Ved regarding what we know from the previous coronavirus infections. 27% of patients have a persistent chest X-ray findings 12 months after the recovery. Important thing is lung function is impaired, mainly the diffusion coefficient, and also the lung volumes are reduced in patients with the SARS-CoV infections. Similarly, when we look at these patients, although the lung function has recovered, patients do find breathless, and this is disproportionate to the improvement in the lung function capacity or reduced exercise, reduced DLC load. So these are the important aspects. Although we say, looking at the pulmonary function, oh, okay, this patient has improved, his pulmonary function is better, but these patients will develop breathlessness. So it is important to assess this way as we go along. This we've been talked about previously, what the COVID-19 SEQUELAE, persistent cough, which has been talked about by Dr. Animesh, fibrotic lung disease, bronchiectasis, pulmonary vascular disease. I mean, this is an interesting aspect. We're looking at COVID-19 patients. There is
Mr. Vinay?
Yes, sir.
Oh,
Any problems?
I think, yes, sir, I think the speaker has lost the connection.
Okay. He came back. Yeah, tell me. Yeah, please. Sure.
Okay, so what we have seen in our cohort of group, we do have seen quite a lot of number of patients admitted with acute COVID infection across our university hospital, and also we have a cohort of patients we link up with the University College London. Approximately 60% of patients who are being discharged after the 3 months have symptoms. And you can see, although there hasn't been an improvement, I mean, this patient has came in with the acute infection, then developed bullous lung disease during the post-acute phase, and then had a fibrosis, which reasonably improved. And in a similar group, when we look at the patients from University College London, when they have looked and assessed about 53 days into the post-COVID follow-up, 90% have improved. And I think that is a good sign. I don't think we are going to see a surge of patients coming to your clinics with a lot of problems, but we need to make sure that we have planning and arrangements for the patients who are severely debilitated or those people who have continuous ongoing symptoms. And it's interesting to see this. The recovery of the patients is low when they have a multiple comorbidities, as you can see in this slide. Long COVID, I think there has been a huge talk about it, and what has been alluded previously, about 10 to 15% of patients, until from the age of 18 to 49-year-olds, will do develop long COVID symptoms, and 1 in 5 of patients who are more than 70 will have the symptoms of long COVID. What is post-COVID or post-long COVID? These are the symptoms lasting for 3 to 12 months, 3 to 12 weeks after the COVID, which is about 10% in mild, also seen in the patients who are not admitted. When you look at the chronic COVID, these symptoms, maybe 1 or 2 symptoms or 3 symptoms like breathlessness, fatigue, and cough, and chest pains, and so forth, are seen beyond 12 weeks. And I think, as previously alluded, it is most likely an inflammatory and immune response, vasculitides, and so forth. And patients with comorbidities exhibited more symptoms at more than 60 days of the follow-up. And what recently published data from King's College have shown that patients who are more than 50, they're obese, or female, group of population people are having more symptoms post-acute illness. So what are we doing? What are we practicing at this moment of time? All patients who are being discharged from hospital, we do attempt telephone clinics 4 to 6 weeks time, ensure they are safe and they are what the symptoms are. And if they are severe and acute patients who are into intensive care unit or requiring non-invasive ventilation or ventilation, we do tend to follow up in 4 to 6 weeks. Then we assess them again in about 3 months' time with chest x-rays, consider lung function, and if there was any PE noticed in acute admission, we organize regular follow-up. We do oxygen assessment, we organize echocardiogram, and if the patients had a mild to moderate and have improved, we discharge the patients. We organize further investigations based upon it, i.e. HRCT, high resolution CT scan, or a CTPA, and we organize patients follow-up according to their needs, not just having an umbrella term. This is recently published by NHS England and British Thoracic Society, how we need to aim for follow-up. I don't want to go in detail regarding this. This is what exactly we've been following for a few months' time, but it is an interesting tool which I think you probably will be able to share with yourself when we do the presentation. Pulmonary rehabilitation, I think it has to be individualized. Although we globally send patients with rehabilitation, it has to be individualized with a chronic pulmonary disease. Exercise is core, but also it is important to enhance a patient's journey through psychological support, nutritional support, and education. So when we look at what we know from pulmonary rehabilitation, what the process and structure involved in patients with COPD and ILD, when do we refer? We refer patients who has a dyspnea score with an MRC grade of 3 to 5 or more than 2 with a functional limitation. We do supervised twice weekly sessions. Now, probably with the COVID-19, we are going to move virtual, like either video recording or Zoom meetings, and encourage the patients to participate at least 30 minutes 5 times a week. We do it for 6 to 12 weeks in total. We do progressive muscle training, resistance training, and aerobic training. We also use adjuncts for that inspiratory muscle training. Whether this is going to apply for COVID-19, will it work? There is some evidence from the previous viral infections like H1N1, but we have to see, and there is an increasing amount of work and literature is being collected to see whether this is going to be beneficial. So when do we consider for management? We need to understand, we need to confirm the diagnosis, whether these patients are COVID-19. We need to exclude serious complications. The patients have a persistent cough, as Dr. Animesh said, we need to make sure that they don't have other complications like as lung cancer or pleural effusions and so forth. We need to support and monitor them, avoiding any invasive investigations. We need to develop the rehabilitation services. So, and specialty clinics. So this is the structure we tend to utilize, which patients and places, the process involved in delivering the rehabilitation, what structure we use, and what outcome measures we are going to achieve. Patients who are critically ill due to COVID-19, either had an invasive mechanical ventilation or a non-invasive respiratory support. Patients who had a pneumonia with symptoms and required oxygen. We use endurance, i.e. post-hospital stay, who have ICU weakness, strength building by patients who have prolonged immobility, including muscle weakness and neurological impairment. We have to develop independence and safety. And the crux point of all of this is oxygen assessment at rest and exertion. These patients, as you know, acute COVID, they may be happily hypoxemic. The patients are talking with you at saturations of 88 on 15 liters rebreathe. But it is important that for their rehabilitation, oxygen, we are prescribing more and more oxygen to the patients who have stepped down from intensive care unit, and we keep on assessing when they are, what's their oxygen levels and during their exertion. We're trying to be generous, but it is important that we can't provide everything to everybody. We probably exclude patients who have neurological disability. If you have very significant neurological disability, patients who have renal or cardiac problems, like in case of myocarditis, current consensus is that we shouldn't be providing them significant pulmonary rehabilitation exercises for at least 6 months period. So they have a gauged amount of exercises. Patients with a coexisting cancer, we can't put them into these rehabilitation procedures. For patients who have severe frailty, so it is important that we need to have endurance, strength, and education are the more key factors. And basis for any pulmonary rehabilitation, this is cogwheel. We just need to keep moving from one place to another place. So what is our aim? Reduce the dyspnea, improve quality of life, improve efficacy, exercise capacity, and improve mood. So what are the exercise trainings we talked about? We talked about oxygen supplementation. You use upper limb resistance exercises, lower limb resistance exercises, not just the breathing exercises, because the muscle in itself, the patient has to mobilize, and then only then you will know whether the patient is breathless. So it is important to use physical aids to improve their muscle strength overall. And there are also non-exercise training, education to the patient. These patients are very unwell. Patients are very critical. Patients are very very anxious about their outcomes. It is really important that we need to provide them education, nutrition support, psychological support, and also aim for symptom control. So structure, what is the site? Where do we provide these services? It is important to find a safe area. The site is important, and I think the government is doing a great job in trying to deliver these clinics and helping the patients. And we also need to know, until we get this vaccine, hopefully there's a good news from the Pfizer recently, infection prevention and control measures are important. So social distancing is important, safe distancing is important. We do pre-appointment screening, so we are bringing the patients, making sure that their family members are not affected. We don't want to bring any acute patients coming into hospital. And the physical structure, making sure that the patient's flow, unidirectional flow is also important. And also decontaminating the usage of instruments and other things are essential. So it's workforce balance. We need to have what we use at this moment is time is consultant as a self, the respiratory physician, a cardiologist has been involved, physiotherapist, respiratory nurses, and very other allied health professionals. We provide, what is the process? What are we doing? We provide aerobic exercises 4 to 6 days a week. We are doing now remotely. It is important that we need to look at the duration, look at the intensity, which means it could be low intensity in the first few weeks. We increase the frequency, and as we go along, we improve the strength of the patients, which is done 2 to 4 times a week, and then functional movement and add weights. So it is important upper lobe and lower limb resistance and muscle strength is improved. We involve active cycle of breathing techniques, inspiratory muscle training. During all this, it is important that we monitor their heart rate, blood pressure, oxygen saturations. We also monitor subjectively what the patient is complaining of dyspnea. What generally we use is called the modified Babu score. And these are the agents. Obviously, we all used it, spirometer and inspiratory muscle trainer. We generally use and give it to the patients. We are also providing oximeters to the patients. The patients can buy it at home, they can record, and it is important that they have a recording of their saturations. Why it is important to adapt to COVID-19? COVID-19 has increased, as we know, about the long COVID, but there is a lot of fatigue. Patients are feeling a lot of fatigue post and we probably are not known what the chronic fatigue syndrome is. I think we thought about post-viral illness, but what we're seeing is patients are educational professionals in their mid-50s are complaining of a lot of fatigue. So we need to adapt ourselves to train the patients to improve their muscle strength, and hence it's an important factor that we need to take into account. There's a lot of mood disturbances we are seeing. Therefore, we need input from psychologists and psychiatrists. And also cognitive impairment. So in not only physical, but it's also important that we need to involve in cognitive functionality. So this is the brief insight into how we are delivering it, how the proportion of the patients are receiving the services. So what are the outcome measures? So we want to improve the patient's physical status, but we use objective measures. We use some treatable traits in patients who are at discharge. So we have a post-discharge follow-up. We do look at their dyspnea score. We look at their cognitive score. We look at the functional score. We look at the depression anxiety scores at 6 to 8 weeks. And there we also review it 12 weeks after the assessment. So it is evolving, and these are the literature and supplement materials which I've used. I kept short because I think some of the things are being covered by my colleagues, previous presenters previously. I think it is well available data from British Thoracic Society, and also there is an interesting publication from European Respiratory Journal and ATS. And so there are quite a lot of good materials how we can develop in these pulmonary rehabilitation services. So I think I'm just going to shorten and quickly give you take-home messages. It is important that we need to understand that long COVID is going to be a real issue. Patients do have persistent symptoms, mainly post-critical care. These patients have multiple comorbidities, and hence pulmonary rehabilitation is an essential to improve the quality of life. And I think the government is already planning. I think workforce planning is essential. Consultant physicians and physiotherapists and so forth, and respiratory nurses should be involved. And I hope I give a reasonably good message, and thank you for giving me this opportunity, Dr. Abba, and the AD government. We can't hear you, Dr.
Thank you, Shiva, for your excellent lecture. Next, we will go to the another topic, Dr. Venkakrishna Sandeep, who is going to present the invasive fungal sinusitis. That is one of the most important one, because with 1 week or 10 days, when the patient took the positive, suddenly is moving outside, so chances of opportunistic infections are more, particularly the mucormycosis, Klebsiella, and everything is. So he done later, so many cases and did the treatment for that also. Now I invite Dr. Sandeep. Can you please share your slides, because time is very short, so you can finish quickly. Dr. Sandeep?
Good afternoon, sir.
Yeah, please share your slides and you can go on.
Can you see my slides, sir?
Not yet. Yeah, now go for the full screen.
Okay. So, good afternoon, one and all. Today I am going to discuss my topic, which is acute invasive fungal rhinosinusitis, which have become more prevalent after this post-COVID era. So, for the sake of yours, I will skip all these things. And coming to the basic anatomy, I'll just tell you within a few seconds. We have four group of sinuses, that is frontal, ethmoid, maxillary, and sphenoid. Any obstruction to this outflow can result in sinusitis, that we all know. Coming to the causes, before we used to know much about viral, bacterial causes of sinusitis, which we always treat with antibiotics and anticold medications. Now, today my focus of interest is all about fungus. Fungus usually occurs in immunocompromised patients and also in immunocompetent patients. I am going to highlight about this source of infection, and I am going to leave about the other ones. So this is very important, right? For the sake of viewers, many people get confused between a normal cold, allergy, and also a sinusitis. I would like to highlight about the few common symptoms that we encounter in a sinusitis. Usually, a patient who have sinusitis will have a longer duration of illness with a thick discharge, and most of them will have a facial pain or facial pressure. Whereas the patients with a common cold, which is because of a viral infection, influenza, and also because of the allergy, the discharge is more or less clear. We call it a kind of discharge with disease course is also smaller course compared to the sinusitis one. And patients with the cold and allergy usually have nasal congestion, sneezing, and cough as a predominant symptom. So this is very important slide. These are the basic symptoms that patients present to us with. So we should easily differentiate between a common cold and a sinusitis, which can always be because of a bacterial or a fungal. So coming to our topic of interest, fungal sinusitis, basically it's divided into a non-invasive and invasive. Basically, a fungus which erodes the surrounding bone, we call it as invasive, which doesn't erode surrounding bone is always a non-invasive one. Coming to invasive fungal sinusitis, which is the one we need to focus today, which is a dangerous and life-threatening form of fungal sinusitis. Before, we used to see it as very rare infection, but nowadays I don't agree with that, because post-COVID, in the last 2 months time, we have seen around 20 cases. So no more it is called as a rare disease. So we need to remove that. And pre-COVID, we used to see this condition in an immunocompromised patients, like post-renal kidney transplant, post-transplant patients, chemotherapy patients, uncontrolled diabetes, retroviral disease, and all these are the most common immunocompromised patients pre-COVID. And the organism is usually mucormycosis or aspergillus and rhizopus in few patients. Why it is called as a fulminant rhinosinusitis is because it has an aggressive course. It extends into sinus tissue, it erodes the bone, and also extends into the brain, eyeball, and also into the oral cavity. So coming to our topic and my case series today. So for the span of last 60 days, we have done around 19, we have seen around 19 cases of post-COVID acute invasive fungal rhinosinusitis, and we have operated on all these 19 patients. All the patients have had uncontrolled diabetes mellitus. All the 19 had uncontrolled diabetes mellitus, and the age group varied from 38 to 62 years and mean age group of 50. And it's predominantly in the males. 16 patients are males and only 3 are females. And coming to their previous treatment, almost all of them took injection remdesivir and high dose of steroids and injection clexane for COVID treatment. And regarding the steroid usage, each one had taken treatment from different institutes or places. So as far as my documentation went on, some people have taken methylprednisolone, dexamethasone around 500 milligrams thrice daily, twice daily. Some of the patients used 125 milligrams of salmeterol as an initial dose, and they kept on tapering it. So each one had a different steroid dosage according to my observation. And interestingly, 2 patients among those 19 haven't received any treatment for COVID. Since they presented to me with typical features of invasive fungal sinusitis, I evaluated them and got an antibody test. And strangely, I found 2 of them having COVID positive antibodies, and they are not aware of any symptoms, and they are purely asymptomatic COVIDs. So then this interesting question came up whether COVID itself is causing such mucormycosis or predisposing the patient to get this mucormycosis. Initially, my observation was like I thought it's because of the steroid usage. But after seeing these 2 patients not using any steroids, I found out that COVID is causing such infection. We don't know yet to, we can't conclude it anymore. Need to observe. Coming to the presentation, majority of them presented between 15 to 25 days after documented COVID infection, after they got tested for antigen or RT-PCR. From that day, most of them ended up getting this infection around 15 to 25 days in between. And these are the common symptoms like vision loss, blurring of vision, proptosis, facial pain, facial swelling, numbness, tooth pain, headache, and all these CNS symptoms. So in my case series, and most of them got blurring of vision and vision loss as their first symptom, followed by facial swelling, proptosis, palatal erosion as the next common. And 2 of the patients presented predominantly with the CNS symptoms like disorientation, with all the other symptoms not having any other symptoms apart from this. She is one of the patient who had a proptosis, vision loss, and a swelling of cheek. So she underwent orbital excimeration and maxillectomy. He is one more patient who had a proptosis, vision loss, and cheek swelling and palatal erosion. This is one more patient who had no symptoms apart from this eroded alveolus and palate. This is one more patient who had a palatal erosion as a predominant complaint. So we have done these basic investigations. All the patients underwent complete blood picture and diabetic monitoring. And C-reactive protein was elevated for everyone. We repeated for every 5 days. Serum electrolytes shown to be the most important lab investigation because everyone had deranged electrolytes. Urea and creatinine were regularly monitored since we are giving amphotericin, and patient had uncontrolled diabetes. And regarding COVID investigations, we have done antibody test for everyone and also RT-PCR and HRCT test. So these are the lab picture that we got by observing all these patients. Everyone had hyponatremia, which varied from 115 to 124. Interestingly, in spite of having severe hyponatremia, they seems to be pretty oriented. They haven't had any drowsiness or anything. And blood glucose levels always used to be very high. And HbA1c for all the patients was more than 10. They have very high CRP levels and increased WBC count. Interestingly, in spite of having such a bad condition, we took the patient up for surgery, explaining the high risk. Everyone came out very well out of anesthesia. And we also did the diagnostic nasal endoscopy, which showed black colored crust and necrosed mucosa. CT and MRI were done to assess the bone damage and intracranial extension. And also we took sinus and parasinus mucosa for fungal and bacterial culture. This is a nasal endoscopic picture. Here you can see the typical black necrotic which is characteristic of mucormycosis. This is the endoscopic picture. This is a sinus mucosa and nasal mucosa. So I will be playing a video, small video. This is the endoscopic picture. You can see the black necrotic mucosa in the nose. This is a typical picture of mucormycosis. Usually the mucosa in the nose is always pale pink, but here it's completely black. This is a CT picture. This is the bone erosion. You can see the lamina papyracea got eroded, flora of the orbit got eroded, and middle wall of the maxilla got eroded. You can see the disease going into the eyeball and also into the nose. This is an MRI picture. Here you can see the sinusitis. This is a pooling of secretions. You can see the disease going into the eyeball. Same MRI. So coming to the treatment, surgery. Surgery, I would like to keep it simple. So it always depends on the extent of the disease. When it comes to nose and paranasal sinus, if it is limited to nose and paranasal, just go for an endoscopic removal. If the disease goes into the skull base like pterygoparatine fossa or palate, go for a total maxillectomy. Conservative treatment is not an option in invasive fungal sinusitis. You should consider this as a malignancy and go do a radical surgery. And coming to the eyeball, if the optic nerve functioning is good, go for an orbital decompression. If the optic nerve is gone and the eyeball is fungating, go for an orbital excitation. No point in preserving the bone because eventually you need to remove it at some point. Same thing I highlighted here. If it is a limited disease, go for an endoscopic surgery. If it is an extensive skull, going to skull base and palate, go for a total maxillectomy. Similarly, eyeball, optic nerve functioning, go for a decompression. Optic nerve non-functioning, fungating, remove the eyeball. This is a similar patient where he has a fungating eyeball and cheek swelling with a palatal erosion. He underwent orbital excitation and maxillectomy. So we preserved the lid and sutured it so that it will be useful for the future reconstruction. This is one more patient where we did a maxillectomy and orbital excitation. Here you can see the optic nerve which got fungated totally. This is one more patient where we removed the eyeball and you can see the necrotic optic nerve area. So in such patients, we can't preserve the eye because it forms the source of infection. Eventually, we will get a cavernous sinus thrombosis. We lose the patient. So we should be radical and aggressive in treating such conditions. Just now this is the post-orbital excitation. You can see the necrotic optic nerve area. This is all necrotic optic nerve. Orbital apex got damaged totally. This is one more patient where we remove the palate. You can see the black necrotic palatal mucosa.
Video is not visible, Sanjay. Yeah. You just go ahead. Video is not visible.
Coming to the medical therapy and all the patients, most of them got, just pardon me.
Yeah, it is visible.
Yes. Coming to the medical therapy, so most of them received injection amphotericin lipid emulsion, which is an amphotericin. Daily dose started from, the dosage is like 3 to 5 milligrams per kg body weight. We started with 350 milligrams on the first 4 days to see whether the creatinine levels are normal and electrolytes were like adjusting to it. So when the patients were tolerating the initial dosage, we increased it to 300 milligrams. We always mixed in 1:1 solution of 5% dextrose and infused over a period of 3 to 4 hours. So the total dosage of this medication varied from 3 grams to 5 grams. We give it in a span of around 12 to 14 days. So this is limited to nodes and paranasal sinus, we give 3 grams. If the disease is extensive, if it involves an orbit palate, we go till 5 grams of total dosage. So once the patient gets stabilized and once we feel that the patient is free of the disease, we maintain him on syrup posoconazole 5 ml morning and night for at least 20 to 30 days. So this is a small chart signifying the role of steroid medication in a particular disease. When it comes to mucormycosis, posaconazole and amphotericin seems to be the superior. And since these patients, most of them had mucormycosis, we opted for posaconazole and amphotericin as the first line antifungals, and two of the patients had Aspergillus, for whom still I gave posaconazole. We didn't opt for ampho, we gave posaconazole directly and they are doing well. Coming to antibiotics, antibiotics were given according to the tissue culture report. And as far as the culture goes, predominantly most of them had Pseudomonas, Klebsiella, and E. coli as the predominant strains. So antibiotic was opted according to the sensitivity report. On fungal culture, we got Vipar in 17 patients and Aspergillus in 2 patients. As I told you, for Aspergillus, we give directly posaconazole as a first line antifungal. And on the follow-up, 18 patients were under follow-up, and of 3 of these, unfortunately, we lost one patient who presented very late and she had a PKD. And we treated the patient for almost 1 month. We did dialysis and all those things, but sadly we couldn't save her. And patients who underwent maxillectomy, the palate was reconstructed in 2 patients with a permanent obturator. They are doing well. So coming to my final conclusion, the biggest challenge in taking such patients is like cost. The cost involved with this surgery or the cost of management, like antifungals and that, is like very high. Since most of them come from a poorer background and all, the cost factor plays a key role in this treatment. And prolonged hospital stay will always add up to the cost factor. And one more bigger challenge is, since they had a COVID infection, they had an uncontrolled diabetes and got treated with steroids, the immunocompromised condition is like a big challenge. We should always work on the immunity thing. And since we use amphotericin and all these fungals and everything, there is a risk of renal failure since they are diabetic, they have a diabetic nephropathy, and also the side effects associated with other medical therapies, high-end antibiotics and all those things. And managing post-operative morbidity. After removing the eyeball, after removing the palate, you know the problems that face. They have slurring of speech, regurgitation of food, and no one accept for an orbital exentation until it is required. So to counsel them, psychological counseling is a big role. So finally, treating success is like early diagnosis, nothing like an early diagnosis. I request all the doctors or like ENT surgeons, or neurologists to kindly consider this as a significant thing, and whoever comes with a post-COVID headache, facial pain, eye pain, blurring of vision, food pain, consider that very seriously, check for their sugar levels, get an CT scan or MRI, and counsel them properly. Most of them will try to neglect the disease, but counsel the associated morbidity and mortality. So early diagnosis will always save the money, avoid morbidity and also the mortality. So we should always opt for an aggressive surgical and medical therapy. When it comes to invasive fungal sinusitis, there is no role of conservative surgical therapy. It always should be radical. Go do a radical surgery and give a proper medical therapy like amphotericin. Complete the course. Don't give a half dose. Then improving the immunity, controlling the diabetic status, work on their immunity, give them antioxidants, protein food, improve their diet. Immunity plays a key role in helping these patients. And last but not least, give team support. You should have a acute team. You have a very good endocrinologist, nephrologist, critical care, and everyone with you so that you can do a consistent and good results. And my message is like, who are treating for a COVID infections, try to formulate a protocol for a steroid use and do a controlled steroid. So steroid access can also lead to COVID, lead to mucormycosis. And also COVID and post-COVID aggressive management of blood glucose levels. Don't take it lightly. Work upon your sugar levels. Take a good diet. And early identification of signs and symptoms to prevent morbidity and mortality. Thank you.
Really wonderful and original case presentation, Dr. Sandeep. So really hats off to you. So you did more than 19 cases you have seen, and really wonderful to see this one. So I request all the participants who are here, so please go through that one any type of headache or otherwise any type of vomitings or blurring of vision, so please refer to the ENT or the neurosurgeon and go for the early checkup. So that is the most important key here. So to finish up this one, so now I request all the panelists to would be go for the quick question and answer sessions. I requested Dr. Animesh, if the allergic bronchitis or the bronchial asthma is causing a lot of complications or the more immune the aggressive inflammatory response, shall we plan for the any different mode of management when the patient presented with COVID with non-asthmatic or allergic bronchitis, or otherwise it's a routine mode of management only? Dr. Animesh, are you there?
Yes, sir, is there.
Yeah. Can you unmute?
Animesh garu, you can screen, you can see the pop-up on your screen. Please click on it.
And unmute all the speakers.
Yeah, hello. Yeah.
I have made a co-host for all the speakers so that they can unmute at own convenience.
Yeah. So, Dr. Animesh, so you heard the question?
No, can I just repeat the question once?
Yeah, if we are thinking that asthma or the allergic bronchitis is more chances of hyperimmune response is there. So, shall we plan for the any different mode of management for these people when they are affected with the COVID?
Okay. Yeah, okay, thank you for the question. So normally what happens is a patient who is asthmatic or is having COPD, so we usually tell the patient to continue with the same management during his stay in the hospital. So in the ward, he can continue to take MDIs with or without cases, and if he's in the ICU, obviously he can continue. You can shift it to rescues and we can continue nebulization, right? But apart from that, so if the patient is requires steroids, we can continue steroids, systemic steroids that is. But there is no such indication of continuing the systemic steroids beyond the period of say 7 days or so in these patients, right? So for the COVID-19 part, there is no special treatment as such in these patients. The indication for remdesivir, steroids, etc., they are same in these patients during the hospital stay. After they are discharged, what happens is we tell them to again continue with their inhalers, and what might be required is that some of these patients might be requiring an increase of titration in the dose of the inhalers or the inhalers. So that may be continued in these patients.
Thank you, Dr. Animesh. So the question to the Dr. Shiva, if what's your experience with this pulmonary fibrosis, how long you are preferring the steroids for these patients?
Acutely, we are just using dexamethasone and remdesivir during acute illness. But in actual fact, when we are following these patients, interestingly, one of the colleagues asked the question. We had a recent ILD meeting. I do part of my specialties in ILD. Is that we are not seeing many patients turning out to be having pulmonary fibrosis for some reason. So we are not contemplating on any increase in steroid usage. When to flip the other side of the question, you have a patients who are on immunosuppressants for ILD, what had a COVID-19 patient, there was a significant mortality during the acute COVID. So we are not using steroids to continuously treat patients related to COVID-19 fibrosis. So there is no current guidance as such. So we are treating acute SEQUELAE, seeing them in 3 months' time, 6 weeks to 8 weeks' time, and then 3 months' time. And if they have any obvious pulmonary fibrosis, then we need to consider use of antifibrotics. But there is no guidance yet. There is no evidence yet.
Yeah, Dr. Ved, so what is the AIMS guidelines for the pulmonary fibrosis regarding steroids? Can you please unmute, sir? Dr. Ved, unmute yourself. Yeah.
Yes, sir. As sir said, there is no data on the use of steroid for post-COVID fibrosis. We are currently don't have any guidelines for that. But role of steroid is mostly in the acute stages where it reduces inflammation. By that mechanism, it may prevent the fibrosis also. But after developing fibrosis, we are not using steroid.
Okay, right, thank you. So, nintedanib causes along with anticoagulants. Any chances of higher bleeding have you observed?
Sorry, sir.
Nintedanib along with anticoagulants. So, if you are using for the fibrosis,
Sir, we are not
continuous.
using nintedanib. As it is a costly drug, and prednisone and nintedanib is almost equally efficacious in the ILD. And there is no data on the post-COVID fibrosis. We are not using nintedanib right now.
Yeah. So just like that routine IPF where we are using the steroids and the mycophylic acid, have you tried in these cases also?
No, sir, we haven't tried enough.
Well, not that much guidelines are there. So anybody wants to raise the hands digitally? So they want to ask any questions? So I think that is Dr. Vinod sir asked him. Yeah, please sir.
Yes, Dr. Rambabga, you wanted to bring somebody who has any doubts? No? Is there anybody who on hand?
Yeah, I am searching them for the anybody is here. Okay, sir. As such, nobody is there, so you can take over, sir.
All right. So, thank you, Dr. Rambabu Garu, for wonderful moderation of this webinar. I thank the speakers, all of them wonderfully spoken on individual topics which we had given to you, especially in Andhra Pradesh. A lot of the doctors, right from PHC doctors, every time I was conducting meetings, they were trying to ask, even with the chief ministers, honorable and respected chief secretaries, meeting also, collectors also requested for trying to understand more what is, how the post-COVID scenario will be, what are the sequelae. So I thank Dr. Rambabu Garu for arranging two sessions. Both the sessions were wonderful, good set of speakers. And from this time onwards, we have started to provide certificate to our speakers for taking their time out from the government of Andhra Pradesh. Otherwise, if it were a physical meeting, we would have were able to actually thank you in person because it is not possible.